where the experts meet. Online learning, practical and sweet. Every Saturday, 9 a.m. Central Time. YouTube, Facebook, X, and LinkedIn. Online.
Hey, good morning, everyone, and welcome to UroNurse. I'm your host, Vic Sinise. Great to have everybody here today. Hey, if you haven't liked and subscribed, what are you waiting for? Like and subscribe. Glad to have everybody joining us here today. We got a great show for you. I'm going to tell you a little bit about our speaker because we got a great guest speaker for you today. And joining us today is one of the most experienced urodynamic specialists you'll ever meet, Vicki Clark. She has devoted more than 25 years to urology nursing, with the last 22 years focused almost exclusively on the highly specialized field of urodynamics. Over her remarkable career, Vicki has performed and interpreted more than 40,000 urodynamic studies, collaborating with more than 50 urologists to help diagnose complex bladder and pelvic floor disorders while improving patient outcomes. Based in Georgia, Urology, in the Atlanta area, she's known not only for her technical expertise and meticulous attention to detail, but also for her commitment to patient comfort and education. Vicki, it's an honor to have you with us today. Welcome to UroNurse. I always hit the wrong button. There we go. Welcome, Vicki.
Thank you. Thank you very much for having me, Vic. Glad to be here.
Right. Glad that we got you on here today. All the way from Hot Atlanta, huh?
Hot Atlanta. Home for 27 years.
Yeah, I've been through Atlanta a few times. We stayed there. One of the SUNA conferences was in Atlanta.
Okay.
Remember, we did a tour of the Coca-Cola building, and nice little town.
Still standing.
Yeah. And Lori, welcome to the show.
Good morning.
Always great to have my co-host Lori on to help us out. And we're really anxious to hear about all your experiences with urodynamics and what you can share. It's a great subject. I've been involved also with urodynamics for most of my 40 years of urology. And Lori, you've been doing some urodynamics, right?
I did for a period of time. Yes. I'm not as experienced, it sounds like, as the rest of you, but I've done my fair share.
All right. Well, we got lots of experience, but let's go ahead and bring in Vicki's slides here and let you go ahead and talk about urodynamics.
Perfect. Well, again, my name is Vicki Clark. I am a urology nurse, 25 plus years. I've been doing urodynamics 22 plus years of that. I've performed over 40,000 tests or more. That's a lot of anatomy. That's a lot of patients' reaction to catheterizations. That's a lot of personal private stories. Everybody knows urodynamics is not the most glamorous test, but I tell my patients all the time, this test is going to hurt your pride more than your body. It's embarrassing more than painful. But then again, it's urodynamics. It's an EKG of the bladder. One fun fact about me is that after I left a 22-year practice, I decided to take it out on my own. I decided to build a business, urodynamics consulting. And a lot of the reason I did that was because the patients were asking more from me. More than just in a clinical setting. They wanted to hear more outside the rooms of what I was doing. And at the same time, I've learned to teach and train and really dig into patient care through my 25 years. I've also learned in 25 years of patient care that if I give the patient enough time to feel safe and secure, they will tell me everything I need to know before I even get started with the test. Like I always say, the test begins with a conversation, not just a catheter. But Vic has invited me to kind of explain how I kind of work my 25 years of doing what I do. And the only way I could really come across that is I'm going to invite you to my clinics. I have taken pictures. I'm going to go over some graphs, how I interpret what I see as I am testing and performing with a patient. So my next graph is going to be setting up for success. Yep, setting up for success. So this graph right here, from the very beginning, before I even begin a patient, I have already called the patient, usually talk to the patient, check the chart. I know what medicines they've been on, surgeries they've had, past surgeries, things like that. That's the beginning of getting that patient to not be so stressed or anxiety before the test. This is the location. This is your time. Don't stress. I'm waiting on you. So the first part is begin, which is talking to the patient. I reviewed the chart called the patient. The next part is when I first initially come into the room, I have to prepare the room. The very first thing I do is set the machine up. Depending on what kind of system you use, I plug the system up, get the system set up, but the laptop is the very last thing I plug up. It seems that the system will turn on a lot better once the system plugs in and then the laptop is plugged in last. As that's firing up, I'm preparing my room. One of the things I've noticed, if you see in the charts over there or in the rooms, I prefer to test my patient on the potty chair. I will hook the patient up on the table and transfer them to the potty chair. The potty chair is much more comfortable. It's a normal positioning, and I do get a lot better readings because the patient's comfortable sitting on the chair. For my room, I also keep my laptop right there beside my patient. I want to read their face. I want to read their expressions as I'm filling them up. Just acknowledging those things with the patient helps me read the test and interpret it a lot better. For my room, I try to keep it as clean as possible. It's a very invasive test. It's personal. I don't like patients to come in thinking, ew, it's not clean. I always leave wipes, Kleenex, everything's in hand reach. When some patients get there, they don't even realize they're having a test. And you know what the first thing they're thinking? Yeah, I didn't even take a bath. Well, here, I don't even have to ask. Here's you plenty of things to clean up. Again, getting that patient in more of a comfortable position to let me start testing. All my supplies are laid out before I even begin. I already know if I'm going to be dealing with some Foley catheters, some suprapubic catheters. Am I going to be teaching CIC training? So again, preparing before the patient ever comes in is really important before I even test the patient. Okay, I'll go to my next slide. So on this next slide, there's a couple tricks that I've done throughout the year, and it just makes my life easier. On the potty chair, you'll see that there's a draped behind that potty chair. That's because when patients come in, men, it gives them a little bit more comfort knowing they have that protection behind them. Again, for me, it's all just getting them stress-free during this test. And again, throughout my other clinic setups, it's always the same. The chair is always close to the table for support for patient for transfers. Easier for them, and they feel safer. And honestly, it works a lot better that they were sitting on the chair. On the potty chair, it's more of a natural voiding position. It's easier, safer for transfers. It's better comfort. It's better comfort for the patient. The room layout, the chair is close to the table. I have worked on Sonesta chairs, but I've noticed for me that they're just not comfortable as they would sitting in a potty chair. But I always keep the chair backed up against a wall too for the patient to rest. Again, as comfortable as I can get them. I stay close to the patient. I watch them. I watch their faces. And I definitely watch EMG activity as I'm feeling. That will tell you a story before the patient even says anything. If that patient's trying to hold, those EMGs will tighten up. The testing catheter. One other thing that I am notorious that patients love is that there's never really a quiet moment when we're in the room. If I'm not testing, I'm teaching. What is your diet? What brought you here? What started before this ever happened? So many times I can find things out that they have done that it's a light bulb. Now I understand what brought you to this position now that you have to have a urodynamics testing. Next slide, please. And on my next slide, as I said, once I get my machine up and running, I can actually test if everything's okay. The basic supplies is a pump tubing, you got your EMGs and tape. The tape is very important. It goes on, but it hurts coming off. All the time I'm telling the patients, the most worst part about this test is the tape removing. But I also followed up with a joke. Here's your free wax tape removal, hair removal free of charge today only. But it's important to have the supplies always handy, all your supplies handy. But these are basic supplies. Once my machine's up and ready, the patient will initially come in, and then we're going to start a uroflow. The uroflow, they come in and just go to the bathroom as normal as possible, and then we catch a PVR. But honestly, that urgency or not urgency to come in when they get the uroflow measurement between that and my PVR helps me know a capacity. Did you have to go? How much can you truly hold? Because if you just voided 500, I'm pretty comfortable putting 500 back in there. So the uroflow versus the PVR does help me set a baseline of the capacity. Next slide, please. So the next slide, I'm going to actually take you through once the patient is hooked up to the catheter. The male catheters can go anywhere between 20, 25. Once you feel it through the prostate, tape it down. Female catheters, really the anatomy of 15, a little less, little more, depending on the anatomy. The rectal catheter should go in about 10 to 12. Once you pass that sphincter muscle, tape it down. The important part is taping these catheters down as close to the body as you can on the insertion. I'm notorious about taping it down because nobody wants to do it twice. Nobody wants to replace the catheters. It's not comfortable with the patient, and it's not fun redoing the test. So on the graph, on the test, you'll see, and I don't have my pointer, but right here at the filling station, at the very beginning of the test, you'll see the spikes. I'm sure, there you go. I'm sure I have put the cough. That first spike is a cough. I'm filling the bladder up. As it's going, the next spike, you see it's another cough. And then at the very bottom, the third line down, you can slowly see the bladder try to squeeze. Stop the pump. It's important to stop the pump once the bladder starts to contract. Don't force the water up against the bladder contraction. Once the bladder starts to squeeze, it's that first squeeze you see. Relax, restart the pump. The patient coughs, bladder tries to contract again. Stop the pump. Let the bladder do its thing. Right now we're observing OAB. The bladder's misfiring. The patient's not wanting to go. It's all the bladder in control. Let's keep on filling. Midway through the test, you're going to see three sets of coughs 2 times. That's to satisfy the insurances. Insurances require us to take the patient through a couple Valsalvas and stress tests. We're monitoring for leakage, stress incontinence, severity of stress incontinence. Moving on, after my 3 tests, the bladder tries to squeeze again. At the very end of the test, we give the patient permission to void. One of the things I'm always training, you can't give permission to void during a DO or overactivity of the bladder. It's already spazzing. You didn't ask it to go. So always at the end of the test, give permission to void. And that means from the baseline pressure, the bladder will start to contract. At the very end of this test, I gave permission to void, and you can see how different the bladder acts compared to just a normal spasm. So going through this test, we get a baseline. Always there's a cough at the beginning and the end of the urodynamics test, and always permission to void at baseline. Never allow the patient to push unless you've allowed them to push. Sometimes patients have to push just to initiate, the contraction. So this is what I see. I see this is a basic test. Let me see my next screen. This is how I interpret this test. When I looked at this test, I see an overactive bladder, multiple DOs before capacity. I actually see obstruction. At the very end of the test, the bladder squeezed with barely any output. I see a cough-induced contraction. The patient coughed, which triggered a contraction of the bladder. That tells me that patient probably pushes to actually go to the bathroom. I see the pelvic floor relaxing during those EMGs and during void. I see an abdominal pressure very relaxed, ensuring adequate bladder function. So all those things I can read on this test right there. And really the patient has guided me through it, stopping the pump, filling up, following the patient's guide. Following the patient's lead, really. Next slide. So this one right here, I know I'm talking fast, but I'm just trying to get through the slides. This is the most common urodynamic mistakes. One of the biggest ones is poor catheter placement. You can see right beside that slide, right beside the wording, look at the rectal catheter, the abdominal catheter. it's out of place. So without that catheter being in place, the whole reading is not adequate. I can't read bladder function when the rectal catheter is interfering with the reading. Don't rush the patient. Rushing the patient makes it do things that the bladder wouldn't normally do. Here's another one on the bottom, poor cath placement. Again, if the rectal catheter is not quiet, then we're not actually can pick up bladder function. There's another graph of a patient pushing. She doesn't know how to avoid butt pushing, but I have to call her back from that. The one at the bottom is a good detrusor pressure, but you see how relaxed the abdominal catheter is? Don't allow your patients to push. Get them to relax. I even step out of the room sometimes to help them go to the bathroom. Don't misinterpret artifact for pathology. On that bottom left screen, I've had nurses say, "Oh, it's OAB, OAB." No, that's not OAB. That's a rectal catheter misplaced. You have to read between the lines a lot when it comes to the urodynamics test. The next slide, please. So a lot of my workflow, it really begins with before the patient arrives. I call the patient, I confirm everything, I read their history because instantly that gives them some more comfort level. I build that trust with the patients. Again, their story tells me automatically what I'm looking for, what I should be mindful for, and even their past. I love to hear about their past, their jobs, because it puts me in a mind state of this is how you treated your bladder throughout the years. Was you holding your bladder? Did you have access to the bathroom every chance you get? Did you have to hold? All those things really play as bladder function. Get a baseline. Catheter placement is super important. Tape it down. Don't let them be jiggling around. They're very sensitive. Those numbers go crazy. Also, the filling phase. Go at the patient's pace. Watch the patient, not just the graph. Keep that conversation going. Keep it light. I'm always talking. The voiding phase. Give them permission to void. Don't let them void during a contraction. Don't let them strain. Let the bladder do the work. All that is basically letting the patient trust to relax. Relax as you're going to the bathroom. And you got to trust your assessments. Trust what you see. A long time ago, very early in my career, I remember a physician telling me, "Vicki, you are the only one in that room that actually knows what's happening." And he's right. And I really took that to heart. Here I am. And after the care, give the patient, hey, you're going to be okay. Here's your antibiotic. You might burn, you might sting, you might bleed. Give them all that information so that when they get home, they're not nervous about, what they see or what's happening at home after they get back to the house. Next slide, please. And my clinical tricks, I've said them already through the whole podcast. My clinical tricks really begins like this. It is that conversation. Because if I can get the patient relaxed and they trust me and they feel safe, they express everything that from the beginning to the end. I don't rush the patient. I sit down, I talk, I pull out. Is it urge? Is it pressure? Is it stress? Is it urge incontinence? Do you feel the need to push? What surgeries, what falls, what diseases, what medications? I use everyday language. I laugh with them. I make sure they feel that they're not alone. I explain to the men like this. I took this verbiage from one of the physicians when I'm explaining to men when they come in, like, why do you have to do this? Because you have a pump and you have a pipe. I am here to make sure and describe to the physician, is it the pump or is it the piping? I have to ensure the pump is pumping. Is it a strong bladder, weak bladder, blocked bladder, nerve damaged bladder, or is the plumbing clogged? One of my favorite things I shared with a patient asking his career, he goes, "I'm a plumber." I was like, "Oh, so am I." Yeah, but I keep things light. Watch the patient, not just the graph. Trust your assessment. Next slide, please. And then again, try to keep it within my 20 minutes. Thank you for allowing me to come in and talk with the podcast today. But if I don't leave anything with you, build trust with the patients before the test begins. If you have a calm patient, you are going to get a calm test. Talk them through the test. Give every explanation. These are the catheters. Treat the patient, not just the graph. I go with what the patient's saying, and then I do my interpretation as we go. And if they jump the gun, I remind them. If they come in and voided 500, I get 100 in there, like, I got to go. I'm like, but wait, remember, you just voided. It's okay. Just relax. Let me fill it up. Good technique, cath placements, where you're putting the patient, all matters. Again, a calm patient is a great test. Every graph tells a story, but when we take the time to listen to the patient behind it, it really makes a huge difference. And that's the truth.
All right. Well, that was a great job. You really,
I've done it a few times.
you can tell you've had some experience at it. And I think we've all had our special cases. And I think the one point that you made that's really crucial is getting the patient to relax. And that's not always the easiest to do, especially some of us guys.
Yes. And it's probably one of the most difficult things to do. Because, it takes, I always thank patients for coming in. It takes a lot of courage to come in to have this done when you know what you're fixing to have done.
Absolutely.
So once the patient comes in, I explain to them, you're here because we need to know what's happening. Everybody's guessing here. So this will at least help clarify some of what you're doing at home compared to what I'm seeing on the test. And a lot of time backing up those conversations is gold. They're already telling on themselves. Yeah, I push a little bit, so I'm anticipating that. I'll pull them back a little bit. Yeah.
Yeah. Now, do you do anything like a urinalysis prior to the test, or check the urine that you do during the uroflow to make sure they don't have an infection?
I do test before, but a lot of times if they're notorious UTI, recurrent infections, I'll be more mindful of testing them. Patients who never have UTIs, I just kind of like, you doing okay? If they have symptoms of UTIs, I'll test it. But yeah, we do test 75% of the patients for that uroflow. Because again, what I've always learned, overactive bladder, you have a lot of urgency and frequency when you have a UTI. You plug that patient up and you miss that UTI, you're actually not diagnosing an overactive bladder. You're really just seeing a UTI of an overactive bladder on those tests.
That can be cause detrusor contractions.
Absolutely.
Like you were showing.
Absolutely.
And this is a kind of a general question for both Lori and I and you. So for the men, do you do them sitting also on the toilet, or do you do those standing?
I do them sitting.
Okay.
But if they tell me, I'm not used to sitting, I'll stand. I'll let them stand during the voiding. I just document patient from sitting to standing. We just kind of hold the catheters to catch as much as flow as we can into the urinal. Sure. But most of the men will prefer to sit. And I'm happy with that too. They're worried about spraying, scattering, things like that. So yeah, if you want to stand, I can stand them up, turn them around. They can void, or you can sit as you will. But with the OAB and urge incontinence, they are much more comfortable and safe sitting.
Lori, how about you?
So I have a couple of comments, questions. That was great. Thank you. This could be like a 12-hour conversation, I'm sure.
It was hard packing all that into.
Right. We get a lot of patients, like you said, are really nervous. And sometimes they tend to tell you they feel stuff. And sometimes I think it's in their head. Like you ask them, do you have a really good urge to void? Are you really full? And they're like, oh, yeah. We utilize a bladder diary, just like you do. We do the uroflow too, but a bladder diary, of course, is something they could do at home, and it's more natural.
Personal.
So if they're saying they have to pee really bad at 100 milliliters, we're like, well, you held 600 on your voiding diary, so we're going to keep going.
Exactly.
Right.
And one of the things I've noticed, I have those patients do the same thing. They'll come in, void 500, I'm getting 100 in there, I got to go, but I'm watching that bladder. And I am able to confirm with that patient, maybe it's the sensation of the catheter you're feeling, because I'm looking at your bladder's not spazzing. You came in here, you voided 500, let me kind of fill it up. I slow the pump. I'll stop the pump. I'll chit chat for a minute. I'll start the pump back up. Patients don't even realize the bladder's filling. But yeah, I have to kind of work through those situations when I know you held 500 and I've only got 100 in there. For me, when the bladder is a true sensation, the bladder's going to contract. Not only that, as I'm feeling, even the slight rise as the detrusor pressure is building they'll get that sensation too. That's not actually squeezing an urgency as much as it is the pressure, they're feeling sensation of the pressure. But they will complain of, catheter's making them feel like they got to go, but it's actually not the bladder. And I just confirm with that with them.
So
And I
I'm
had
gonna
a sorry.
I'll interrupt you for a second. I'm going to give you a tip because I was asking about whether you do men sitting or standing, and I give men their choice, just like you said.
Uh-huh.
But I found most men prefer to stand, so I usually try to accommodate for that. Now, I came up with a trick because I was at a gas station and I saw these funnels that they used so you could put oil into your car. It's a paper funnel. It's got a hole in the bottom. It's not very big. So of course, I took a few of those. I tried those out on male patients. So you got all these tubes, which are going to make things spray anyway.
Right.
They put their penis into that funnel and it keeps the spraying from happening. And they get a really good urination with all the tubing in there. And it worked for me. So I found a way of doing it
without spray.
Not so messy, without the spray.
Yeah, that's a good way of doing it. It especially keeps them from being embarrassed.
Right. My other question, I know you showed the graph with the OAB. What if we come across this quite a bit, and I think we have different ideas on what to do, but as far as if they do contract and they're not able to hold it, and every time they contract, we slow down the pump to barely, just really low.
Right.
And no matter what we do, they contract, they void. They contract, they void. At what point do you say, okay, this is our test and this is what we see and we've got our information? Of
course, it gets to the point you could do that all day.
Right.
You could watch it squeeze, here it leaks. You could watch it squeeze, here it leaks. So I'm getting the documentation, OAB, UUIs, everything. But then it comes to a point I have to give them permission to void. I have to give that patient permission to void to let me see the bladder and the brain are connecting. Or can you control that bladder function? I already see it's controlling you. Mm-hmm. Now I want to see if you can control from baseline. Because again, I'm already documenting, yeah, you got UUI, and I confirm with that with the patient. Is this what happens? You're not making it to the bathroom? Oh yeah, every time I'm going to 15, 20, depends a day. But there comes to a point after about 4 or 5 contractions, it just could go on and on. Mm-hmm. Then I'm like, I got to give up. Now I need to show the physician the patient can be in control of that spasm. I'll get as much as I can. I'll stop it. I don't care how much is in it. Let me see if you can make the bladder squeeze. And then at that base pressure, they'll think it. Then I'm able to get it accurate, at least a function that they can control, not being controlled. But yeah, it'll just come to an end. I'll stop it like, okay, I'll have to stop, get a little bit in, but now is your permission to void. Do what you got. And then I can get actual detrusor pressure.
Thank you.
We have a question that came in from our audience. I'm going to bring that up here. I think it's a great one, too.
Oh, no.
What's the different placement? What do you do if somebody's got a colostomy? They don't have a rectum that you can utilize. And assuming they're not a female patient where you could place it vaginally.
Right.
How you can get your true detrusor?
Right. So one of the things, and I get those a lot. I'll have patients with a colostomy. There's no rectum, but I've learned just to leave it out. You can guide that patient and know how to read a jagged push or a natural squeeze. Squeezes are round and soft. Pushing, it would instantly be jagged, like a sharp edge, like goes up, jagged down. That's forcing the water out. But if I'm trying to just get bladder function, is the bladder working? I get the bladder. I tell the patient straight up, I normally use a rectal catheter, but the purpose of it is for you not to push. Because I'm not using it, I can't, you could trick me here. So on permission to void, I get the patient to relax, and I can tell just from the relaxation, how the bladder's acting. If you have to get bladder detrusor of a patient with a colostomy like that. And there's patients, that sometimes, well, even with the females, if you get traumatized females and things like that, yeah, you're not going to get that rectal catheter. Again, I'll place it into the vaginal vault as well. Any kind of trauma, I try to make it as easy as I can for the patient, depending on their history.
Yeah, absolutely. I agree 100%. If you don't have a rectum, you don't, and you have no way to place a catheter for the abdominal pressure. And as your point is well taken. Normally the flow you'll see when they are pushing, it's jagged, it's up and down.
Yes, It's quick.
And then if it's the detrusor is more rounded,
Yes.
so you can kind of determine between those two.
And it's a buildup. It's a buildup to a squeeze, and then it goes down. If the P vest is just shooting straight up, they're pushing.
Yep. Yeah. Good point. We have another question from our same King Wang. Do you ask the patient to use an enema before your dynamic study?
So when I first started in my career, I did. I was big time on it. But as I went on, I noticed that really causes more trouble than it was worth. Because when a patient comes in, a 9 o'clock appointment, 10 light night enema, morning enema, the rectal catheter is out of control. They're trying to hold, bowel movements, everything else. So I've learned it just is more of a hassle to read that. So honestly, when I'm using the rectal catheter, or when I'm talking to the patient, I'll just try to tell them to have a good bowel movement. But a lot of it doesn't interfere. A lot of times I'll use the rectal catheter. It doesn't go in, but just a few inches in there. But yeah, I've kind of just told the patients at this point in my career, let's don't worry about that. I'm getting just a good accurate test without you feeling on edge like you're gonna poop.
100%.
Yeah.
You're gonna have more than urine in that.
Yes.
Right.
Lori, same thing for you. No enema.
Yeah, no, we don't do enemas for that reason, because it's you get those people come in when their rectums are, contracting and stuff, and it's a mess.
You can't get good readings. I mean, really, you have to quiet the rectal catheter.
Actually, I found the secret for me to place a rectal catheter is put the catheter on the tip of your finger and then just insert just so you get beyond the sphincter.
Yeah.
And then you can kind of push it up a little bit easier. So if you just try to feed it by itself, it'll get tangled, and if there's stool in the way, you'll never get it around. But you can with the finger.
And it should never hurt. I mean, I tell patients, honestly, one of my selling points, I've done urodynamics on myself. But when I done myself, it really built my confidence, because I was like, that wasn't that bad. The rectal catheter you barely felt. But anytime, that's why I tell the patients, you'll barely feel me put the rectal catheter in, but I am going to lube it up. I'm going to make sure I rarely have to go twice. Like I said, I'm down there. I'm going to take advantage of me being down there. You only want me down there.
You mentioned about the taping. That's really important. The last thing a patient wants to do is have to have you go back in and put
absolutely
back in. Tape the heck out of them.
You better believe it. And one of the things I do about the taping with the EMGs, you have 2 EMGs that sit, I call it on the starburst. I'll slide my rectal catheter to the right or the left, but I put the tape over the EMG so they're not touching each other, connectivity, when the patient's actually sitting on the chair. Because if it is, I can see it. It fires up on my test, and I'm like, it's too much for a patient to go through to not get it right.
Mm-hmm.
All right, we have another good question that came in from Raj here. What fill rate do you use?
Depending on the patient. If the patient comes in, they're a high, 600, 700, I'll fill it at 50. OAB, I'm slowing it down. If they're stressed, I'll slow it down and kind of, put it up as I'm testing the patient. But at a normal rate, I'll usually start about 40. If it's a big bladder, I'll bump it up to 50. That's normally what I would start with, depending on the diagnosis, really.
Yeah, it's a good point. If you see somebody who comes in and they've got probably a flaccid bladder, you catheterize them and got 600 cc's out. Yeah. It's gonna be a long time to fill it.
It's gonna be a minute. That's right. Fill it up. Fill it up. But if it's an OAB patient, I just kind of take the time, fill it up, just let it. Half the time the patients don't even really feel the water go in. I'll tell the patients it might feel a little cool, but that's really all you should feel. I'll even tell patients, women have told me through the process, that feels kind of good because the water's cold. It's like a good washing at the same time, but feeding that patient's information from other patients, they love that. They just kind of relax with me, It's not my first rodeo.
Yep. Lori, what's your thoughts on fill rate? Kind of go along with it?
Absolutely. I mean, we've gone so low with OAB people, but when you get somebody who has had a leader in their bladder, and their bladder is, atonic or flaccid or what have you. And I'll start out at the norm with them. But if I'm not seeing any activity, it's going right up.
Right.
Yeah.
Yes, absolutely. You'd
Now,
be sitting there
sometimes
an
this
hour.
feed will elicit a detrusor contraction, and it could just be fast fill
Right.
causing it.
That's
So
right.
I usually drop it then if I start seeing that, and just to see if I'm causing the artifact
That's
or
right.
not.
Mhm.
That's right.
All right. Now, this is another good one. Wow, we got some good questions coming in here today. What's the max volume that you'll put in? So you got that flaccid bladder. Where do you call it? Hey, that's it. I'm not putting any more in.
So a couple things that I've had to actually talk with the clinics about when it's scheduling urodynamics.
Mhm.
It's a protocol for us. Like if the patient ends up in the ER and he has 1,000, 1,500, 2,000 cc's for whatever reason, ended him up there, that patient has to keep that Foley for 30 days before I even try to fill the bladder up. It's already distended. It's not going to do no good for me to fill it up when it's been traumatized within these last couple of weeks. So I would normally wait 30 days before I try to fill the bladder up because the capacity will go down. So if I had a patient that came in a situation like that, I would feel comfortable filling them up to a 750, 800, even to 1,000. If I saw on their chart that they was in there for 3,000, but normally after about 1,000, I really don't want to go no more 850 to 1,000 because if you're not peeing at 1,000, you're not going to be peeing at 2,000. I'm not going to get a detrusor pressure either way. But waiting those 30 days after a cath placement on a large retention bladder makes a huge difference because after I get them back for 30 days, I'll notice, oh, you hit 1,500 in the ER. I can't even put 350 in there now. That's how much the bladder will shrink after it's been, resting, decompressing for a while.
Lori, what were your thoughts on where do you call it quits when you're filling basically a hypotonic bladder?
I will call it quits at 1,000.
Mm-hmm.
No need to fill them anymore.
Right. Not when the
No,
normal.
I won't even go that far. Usually 600 is kind of where I draw the line. At 600, especially if they have no sensation. I see a flat line.
Right.
There's no sensation. At 600, it's kind of you've proved your point.
I guess it depends, because you've got those people with those very high residuals that still do pee on their own. And so I want to get them up to at least where they can possibly pee. But if you get a Foley patient and you know that it's probably not, they're not going to be able to pee, then I will push it to 100. Excuse me, 1,000. Here's
an example of a patient I had just yesterday. And this patient came in. He has been self-cathing for 2 years, twice a day. Twice a day for 6 years. Normal voiding is 6 to 8 times a day. So when someone suggested he catheterize himself twice a day, I already know he's in retention. Where's all that urine going if you're not emptying your bladder? So they send him to me to look for bladder function. If the bladder's working, then we're going to exonics him. Well, you've not maintained his capacity at a normal capacity. Right. So I take the patient. He doesn't feel like he has to go. He empties his bladder. He's a CIC patient, empties his bladder. 900. Didn't even feel like he had to go. I got to at least get 900 in there.
Yeah.
So as I get up to 900, guess what? The bladder, a little bit of detrusor pressure. If he would have been taught self-cathing a few more times, he could have lessened his capacity and probably had better bladder function. But
that's kind of crazy. I mean, that's for somebody who's carrying a residual, but still voiding. You know, I always say you don't want to have a residual when you go to catheterize more than about 300, 400 cc's.
Yes. Especially 1,000. So I had to, ever so gently say, you need to pick up a few more catheters. Let's retrain your bladder. Let's bring that residual down. Those urges might come a little bit quicker. You have to get to 1,000 before you can even feel like you have to go. So let's self-cath and keep those residuals more at a normal base. So that way you could possibly bring back the detrusor feeling that you're going to get. Because he felt it at 1,000. I saw it at 1,000. So I'm sure if we could lessen that residual, he'll get a little bit more sensations.
We have another question coming in here from Michelle Johns. Our office places the abdominal catheter in the vagina since we're urogynecology. Is this as accurate as placing in the rectum? What are your thoughts?
I work for Atlanta Women Health Group. And it really is a preference. I mean, I will put the rectal catheter in the vaginal vault as well. And honestly, it does read just as good. Looks good to me. I don't get a lot of artifact. Again, if I have somebody with a lot of bowel issues, I'm feeling kind of like, I got to go. All right, let me just put this over here. I'm not even going to go that route, but yeah, I'll put it in the vaginal vault just as easily and tape it down.
Do you have a harder time though, when it's in the vaginal vault from it sliding out?
It depends on, the anatomy. If the anatomy is all in my way, I'm on a second guess. But when I do place it in there, I place it to about a 10 to 15 and I tape it together with my urethra catheter. So they're together in one piece because it's about the same length. So once I tape it together, it doesn't move. Again, that tape that you use is gold because it's going to get wet down there. Who wants to be putting that stuff back and forth? So like I said, that's where I spend, and that's where I teach my nurses, spend a few extra minutes right here. Because this not spending a few extra minutes is going to send you 10 to 15 minutes redoing it.
I found that usually the vaginal was a better reading because there is still some peristalsis with the bowel tissue. So you pick up a little bit of, not quite the full contraction, but you can see some of that showing up. And for some men, or some, rectal ones pick up more. Vaginals are usually very stable with what patients are doing with coughing and stuff. You can see it.
Absolutely. It's a lot quieter, as I say.
Yep. All right. So Francine Palmer, welcome to the show. A newbie to urodynamics. Only done 3 so far. Well, that's definitely a little under your 40,000. And I quit counting after 40,000.
I have.
Taping to the tip of the penis, finding the catheter can slip out of the urethra, even with tape, especially when they cough. Any suggestions? Oh, this is a good one.
I read it again. I didn't.
So you should be able to see it on the screen on the bottom here. It says, with males and taping the tip of the penis, finding the catheter can slip out of the urethra, even with tape, especially when they cough. Any suggestions? So basically, how do you keep that catheter from moving on a male patient?
Right. I have been through numerous different types of tapes, because you have to tape it to the penis. But I have come with my plastic, I call it the plastic tape. It holds better, but coming off the patient, it hurts worse. Mm-hmm. But again, just for that piece, just for those few moments. So once I get the catheter in place, I will just put one piece on the head of the penis, and then I pinch the rest of the tape over the catheter. I used to twist. Yeah. But that tape is so sticky, now I'm just embedding it in there into that catheter, and it will stay in place. But here's another thing. Depending on your positioning of the patient, when I'm positioning my patient on that potty chair, I make sure that catheter that's in the penis has a little curve in it. I'm not letting it hang. It ain't pulling. I'm keeping it up and secure, high on the thigh, all the way up into placement. And then once they sit on the chair, it's still right there. Nothing's pulling, nothing's tucking. Because if you tuck it in, that tape will kind of help secure it just a little bit for that. Yeah, but it's all in the taping.
Now, from the male perspective, please keep that tape off the tip of the penis. It's much easier to peel it off of the skin behind the penis than it is off the tip. These guys are going to be moving.
You'll be all right.
Yeah, when I was teaching urodynamics too, they were having problems with it slipping out, even the rectal and stuff. And I'm like, you need to shave the area. If they have a lot of hair, shave it.
Just shave it to one side a little bit.
Right.
Anything.
Now, the one thing, since I'm doing them mostly standing, I always give the guys the option. If they want to sit, they can sit. But if they're standing, then they can actually kind of hold it so that it doesn't slip out as they're urinating. Because that's when they could typically will come out while they're voiding. They'll just void it out. But if they hold it in front and they're not, keeping their hand out of the flow of the stream, of course, with my funnel, it works real easy. They can prevent that from coming out too. So,
even with women, even with women, the catheters will slip out because they don't go in as far as the male catheters. So there's been times when that bladder squeezes, there ain't nothing going to stay in there. That catheter will just keep falling out. I will ask the patient to hold the catheter in place. Just reach down there and hold it for me. Just another second. I got to get that detrusor reading. Just hold it for me. Right. and that helps a lot too. It's a little extra work for them, but hey, they're willing to help and get out of there.
Yeah.
Let me tell you, they don't care about the extra work. They care
Nope.
about having you put another catheter in them.
That's right. Yeah,
Right.
because if you remind them, if it falls out, I got to do it. What you want me to hold?
Yeah. Oh, I'm holding that thing. Don't
I'm
worry.
holding.
Oh, we've had a lot of great questions come in.
Mhm.
I'm gonna throw one last one up here for the whole crew,
Sure.
and you should be able to see this one. What is the most challenging urodynamic case you've ever encountered? So we'll kick it off with our guest, Vicki. What's the most challenging urodynamics that you can share with us?
I feel like the most challenging is not it's the patient's ability to move and transfer for me. Their ability to just be able to transfer, let me hook them up, like that's the hardest part, because once I get the catheters in place, I feel like I'm gold. I got it, But now if I have to move you, catheters are pulling, wheelchaired patients, patients who aren't mobile, they're harder to shift. And them advancing the catheters, pulling them out are even more at risk like that. So yeah, for me, because I'm under 5 foot, that's more of the challenge of just repositioning the patients for there. Now I have patients that I would rather patients who don't speak any English at all. Those are challenging. But like we always say, a lot of what you're in there for, So a lot of times, even just a little bit of interpretation for me at the beginning, I can guide the patient through the rest of the test. I can tell you how to cough. I can tell you, it's okay. There's all kind of sign languages I'll leave with the patients. But yeah, my most challenging would probably be the ones that the patients are hard to get to. The anatomy might be hard, is way up there. I'll run into blockages, but those are usually normally my challenges.
Yeah. And Lori?
Yeah, I was going to say the exact same thing.
Yeah.
People who can't ambulate well,
Yeah.
The heavier set are harder to get it positioned on the commode.
Yes.
So
Mhm.
because the commodes are not always, friendly to people who are heavier, and it's harder to position them.
Right.
Yeah.
That like the patients always tells me, you need to tell them one size doesn't fit all on them chairs, because they do. It can be a tight fit. But there are times if the patient is a tight fit, I'll do them on the table. I'll lay them on the table and test on the table. If I'm just looking for detrusor pressure, then I will do the patient on the table too.
Yep.
So for me, it's always been like the younger men that'll come in that have to have this test, only because they're at high risk for vasovagal. I mean,
that one too. That one too.
And you're trying to recreate something that's very supposed to be normal in an office, which is far from normal.
Absolutely.
And then, you want to try to give them some privacy, but you don't want them passing out and getting hurt.
Exactly. That's why when I was showing my room setup, all my chairs are pushed against the wall. That makes me nervous too. Those young patients, when I see them on my list, I'm like, oh Lord, come on, let's not be passing out. But I sit so close to the patients that they start turning white. They start sweating, but I'm right there. I can put my hand on their chest, hold them up, do what I got to do. But I've realized until those catheters come out, they take a longer time responding. Yeah, they take a few more minutes coming around. But by the time you're pulling them out and they're hitting that vagal response, they're already, they don't even feel anything after they're already in that response.
Yep.
Yeah. Well, Vicki, it's been a great discussion. We've had a big audience today. A lot of live questions coming in. That's great to always have that. Really appreciate you joining the show.
You're welcome.
Just saw you on LinkedIn and reached out and thought, it's nice to hear how other people are doing urodynamics. I've spoken about it in the past, but I really liked how your technique, of calming down the patient.
Absolutely.
That pre-study before you even see the patient, kind of knowing what's going on with them is really important.
Mm-hmm.
These are kind of things for people that are new into urodynamics. I'll warn you, you're not going to know anything after 3 urodynamics. Probably after maybe doing
about
50
a year
urodynamics.
Years.
Yeah.
I've walked up on I've walked up on clinics and they're just, it's not a plug and play. You got to sit down. You got to sit down and engage. For sure.
And study the neuroanatomy, understand how a bladder functions.
Yes.
The nervous control of.
Yes. Know your normals. Know your normals.
Right. If you know what to what you should expect, then what's going wrong is easier to see. And
Correct.
I think, you could train a monkey to put all these catheters
Sure.
in and turn the machine on, but you're going to get, useless information out of it. I've seen a lot of bad urodynamics. So.
It's all about documentation throughout the study. What are they doing at every point of that study?
Yep. Every pressure, every tracing,
every feeling, every
Yep. So we've had a bunch of thanks from the audience about your presentation. They loved you. Yay! That means you got to come back sometime and do this again.
I'd be happy to.
And next week, I got a little teaser for next week's show.
Watch this CME and CE accredited on-demand webcast featuring Charles Bodine, MD, for a concise case-based review of evolving best practices in bladder cancer care. This program examines how recent advances are shaping personalized management decisions across the disease continuum, with practical insights on treatment selection and adverse event management to support the safe, real-world implementation of these agents in the clinic. Join us on July 4th at 9 a.m. Central Time to learn more.
So yeah, 4th of July was our next time here. So I decided I'd do a one contact hour, free contact hour. But come and join us for that. I've watched it already. It's on bladder cancer. It's really good, one not to miss. And you get that one contact hour for free. So join us next week and don't get injured on that 250th anniversary fireworks show.
Yeah.
All right. Well, thanks again for showing up and giving a great presentation, Vicki. And Lori, always great to have you here. Any big plans for the 4th of July, Lori?
Oh, my sister's she's got a pool in her backyard. So she's having a pool party with a band and all this good stuff.
Oh,
so
that's fun.
Yeah.
That'll be fun. It's supposed to be, I think, like in the 90s.
Yeah.
Great day
How
for
about
it.
you in Atlanta? It's going to be a little hot there too, I would think.
It's going to be a little hot. Actually, tomorrow's my birthday. I'm having a luau party.
Wow.
Yeah.
Happy birthday.
So we're celebrating. That's the best thing about having birthday around the 4th of July. Everybody's off. Everybody gets to come.
Good.
And now that you're turning 21, you could even have a drink, right?
That's right. Drink for two.
All right. Well, everybody else out there watching, stay safe for the 4th of July. We'll see you for that contact hour. And thanks for coming.
So here's to the mornings, the coffee, the monitor glow, to the wisdom he shares and the folks that he knows. Saturday is special when Vic's on the stream with 40 years of knowledge and a head full of dreams.